guide us as we study. You give us understanding. You will give us the grace to retain what we read. Lord, we pray that the knowledge will be used for the glory of your name. As we seek forth your kingdom, your Lord, that things will be added unto us. So thank you because you answered us. In Jesus' name we pray.
Amen. Amen. We stop at question number 9. What is the risk pattern? What is the risk pattern of this regarding the side of subsequent invasive breast cancer development?
Oh, this thing is not very clear. What
Okay.
is the okay? This is contralateral risk only.
That's how this is.
Unlike globular carcinoma in situ and ADH, which are bilateral risk.
Okay. 5% is lateral risk. Question number 10.
Let's see. Oh, I'm very clear to me. Okay.
Yeah.
Okay, yeah. Which statement best describe the book?
Because younger patients have higher recurrence risk at the age. Number 11.
Okay. It as I mentioned this, with a nuclear grade and several measure, what is the final score and risk category? Don't remember that one again. Low risk. Says one is okay. Okay, low risk. Sorry, let's revert that Van's score. Van's prognosis index. Yeah? Did I take note of it the other day? Sorry, let me see.
This is it.
Okay. What does it does? It's a scoring system stratified years based on the risk of requirement after treatment. The status scores 1, 2, or 3 in each of the category. 1, 2, or 3 in each of the category.
I think this juice.
So 1 is 1, 2, 3. So it's 15. So we have size, nuclear grade. Okay, that I think the other day I was talking about nuclear grade and what? Distance from margin. Okay.
So are you done with this?
Sorry,
Hmm?
less than 1 mm. Not yet. Low, okay. Intermediate and high. Okay. Okay. All right.
What's the answer?
No, is is low risk. A.
Good. The answer is A. Number 12.
So which marker is more likely to strong in low grade science? ER, ER, strongest in along with PR. Okay, ER, intriguing receptor. It is given to the elation from the margin in the van. That is 3.
Well,
13
that's the one we type.
is C.
Yes, that's for the margin. What is 2?
Hmm.
What is 2?
1 to 9,
What is 3?
greater than 10.
10 or more. Yes.
Sorry, 3 is less than 1.
Yes.
2 is 1 to 9. Then 1 is greater than 10.
It's 10 or more now.
10 or more. Okay, okay.
Yeah.
10 or more. Okay.
Drink coffee, we can move it. Huh. What is the proposed benefit of ensuring at least 1 cm margin in low grade DCIS?
Reduce risk of recurrence. Let's see. B. Reduce recurrence rate by ensuring
Yeah.
the ensuring the removal of discontinuous focal.
Question number 10. Which of the following best describe the recurrence risk of high risk DCIS?
High recurrence rate.
Remain high despite radiation.
Mm.
And that's why mastectomy is required. You don't call mastectomy.
Mm.
They don't mind me. I ask foolish questions at times. So mastectomy is done for what kind of DCIS?
High grade, high grade.
I agree. I guess maybe for low grade you can do lumpectomy. I've seen lumpectomy done before. A lot of lumpectomy, but I've seen cases of high grade. You see this size, mastectomy is done for this size. Why? Because there's high recurrence rates in patients with high risk DCI. If you do lumpectomy and radiation, it doesn't wipe away. So you have to actually do lumpectomy. I mean mastectomy because to get very, very wide margins, very, very wide margins to be able to, for high grade DCIs. Of course, high grade DCIs, we know already what it is. Okay, good. The next question. 1 minute, let me watch it. So what's the answer? I'll give you 60 seconds.
I can't see it very well. It's not clear.
I will share my screen again. Jesus can help me. Jesus alone. I must tell Jesus. Hey, key features of male breast cancer included the clinics. I say B.
Key features of breast cancer includes all of the following set. Mm-hmm.
I say B.
Okay. No, I've not answered.
Uh-huh.
B.
Let's go with B. How long can you, what are you going to work tonight?
No.
How long can you stay?
Let's stay to four and see.
4 is how many hours from now? That's 2 hours.
Mm. If I can stay with it, I'll let you know. So the two main best answer for rest of it is associated with sexual progressive and female.
So this is wrong. They say C, the answer. Yeah, agree.
Okay. I don't know what is the answer, but
Yes,
from
yes.
the book is
They are correct. Mr. Chat is right. So let us expand and let us deal with this issue quickly. This time around, we're going to be this one is going to not going to take time. You're going to see. You're going to see. It's not going to take time. You'll see it. We're almost done with this very soon now. But this one doesn't have much pictures to look at. Let's
Mhm.
expand it and see. So let's start with question number 1. The statement is this: hereditary forms of male breast cancer are associated with BRCA2 germline mutations. This statement
It's
is
true.
true. So BRCA2 germline mutations is the most commonly implicated genetic alteration in hereditary male breast cancer. You know, I'm serious tonight. You know I'm serious. You know why?
Okay,
Because of the,
I'm listening to you.
because of the new pope. I want to be serious.
Mm.
Other genetic syndrome associated with the male breast cancer include androgenic receptor mutations can occur leading to breast cancer, TP53 mutations, B10, leading to Cowden syndrome. What are components of Cowden syndrome? What is the Cowden syndrome triad?
Mm. So,
Hmm? You know the funny thing, I read it, but I forgot. I used to, let me quickly pick up.
I'm with you. I'm with you.
Okay. Uh, Cowden syndrome triad. There's a triad for Cowden syndrome. Expand and explain. So Cowden syndrome is a P10 mutation. Pathology board exam, then
Okay.
it's a high yield topic for pathology, intersect genetics, oncology,
Yeah.
P10 stands for phosphatase and tensine homolog deleted on chromosome 11, 10. So usually for high immunohistochemistry, you see lots of P10. You know, it can be used to do it in endometrial cancers too. If there's lots of P10, that can be a sign that there's cancer. This negativity regulates this negativity regulates PI3 kinase AKT mTOR pathway, which is critical for cell survival. And, you know, let's look at it. Cowden syndrome. Alternate name is P10, hematoma tumor syndrome. You understand?
Yeah.
Because it's an autosomal dominant with high penetrance and very great sensitivity. So the clinical features of Cowden syndrome, yes, there has to be skin, trichomonas. I think we mentioned it before.
Mm.
Trichomonas, isn't it? You see the trichomonas. Let's see, classic triad: breast tumors, thyroid follicular disease, endometrial cancer, and mucocutaneous lesions like trichomonas. So for skin, you have trichomonas, facial papules, oral mucosa papillomas, acral keratosis, breast, multiple fibroadenoma, high risk of breast cancer, thyroid, multifollicular goiter, follicular adenoma, and the rest, endometrial cancer, and the rest. So pathology will have breast, fibroadenoma, adenoma, papillomas, multiple fibroadenoma. Invasive cancer can be there, thyroid, follicular carcinoma, unlike papillary carcinoma, which is more common in general population. This one high risk of follicular carcinoma, follicular pattern lesion, then CNS, lemidoclus, hematomatous polyps in GI. So there will be lots of
Leamadoclus disease.
what do you call that? Leamadoclus, you know it?
Yeah, CNS.
Yes.
Enlarged cerebellum. Enlarged displayed ganglia cell within the cerebellar cortex.
Hmm.
Hematomatous polyps.
Hmm. Okay, good. So the major criteria is breast cancer, thyroid, lemidoclus disease, mucocutaneous lesions, and macrocephaly. So breast, thyroid, minor criteria, GI hematomas, and the rest. So I have two major, one major. So different STK11 increased Jaggers mutation. I mean, these things, the faster we are, the better for us because this thing never keeps, you keep forgetting and reminding. HPS,
ETK11.
HPN, STK11 is increased Jaggers syndrome, polyposis, and mucocutaneous lesions, GI hematomas, pleural lentiginous. P10 mutation Cowden syndrome can associated with breast cancer of males. HMPCC can associated with breast cancer of males. CYP17 polymorphisms. BRCA2. So what's the most commonly implicated mutation in breast cancer of males?
This is BRCA2.
What are
Just
the
it.
what are other things that can lead to it, predispose to it?
Androgen receptor mutation, T-pituitary mutation is Lymphomani syndrome,
Mm,
HMPCC in Leach syndrome, CYP17
polymorph-
polymorphism.
Hormone receptor positivity in male breast cancer. The statement states that male breast cancer is more likely to be estrogen receptor positive than female breast cancer. Surprisingly, that's true. Male breast cancers show higher rates of hormone receptor positivity than female breast cancers. Estrogen receptor positivity is 90% of male breast cancers. Progesterone receptor also higher than in females. This makes endocrine hormonal therapy an important treatment component for many male breast cancer cases. I actually thought it would be the other way around since men don't produce estrogen. Surprisingly true. That means maybe in the first place, that patient with Klinefelter syndrome that developed breast cancer may have been the result of high estrogen. Number three, statement is, they say false. Male breast cancer corrected for stage is associated with a worse prognosis than female breast cancer. And the answer is false. Why male breast cancer presents at a more advanced age? When matched stage for stage with female breast cancer, the prognosis is equivalent. The overall survival rates seen in male patients are mainly because they are diagnosed. The worst overall survival rates seen in male patients are mainly because they are diagnosed later due to inherently worse tumor biology. So the prognosis is not worse when corrected for age. So when corrected for age, they have similar prognosis. Do you agree?
Yeah.
Yeah. Risk factors for male breast cancer. Western countries, increasing age, obesity, exposure to estrogen, ionizing radiation, Klinefelter syndrome with 50-fold increase. Additional important fact, a history of male breast cancer increases the risk of contralateral breast cancer by 30-fold, much higher than a 2 to 4-fold increase risk in women. This highlights importance of vigilant follow-up. So can you agree with the risk factors?
Mm-hmm. Yeah.
Stage at
It's
present,
similar to what you find in female.
yeah. Stage at presentation and prognosis. Male breast cancer is typically diagnosed at a more advanced stage than in females. Why?
Mm-hmm.
It's on the
Lack
screen.
of awareness,
Yes, lack of awareness,
less breast tissue.
less breast tissue, yes. That allows it to become stage 4 quickly. It begins to invade the adjacent structures. Understand? Overall poor prognosis, even though the stage corrected prognosis is similar. Overall, it comes out late. Okay, good. Now, male male breast cancer corrected for stages usually worse prognosis than female breast cancer. It's
It's
false.
false.
Okay, good. So let's read through this. So what's the incidence rate of male breast cancer?
1% of all
Breast.
breast cancer
At
in
what
US.
at what stage is almost half of it diagnosed?
Well, it's in the elderly. Where is it? Where are you reading from?
Yeah,
It's
stage
in the elderly patient.
at what stage? At what
Three
age?
of three or four. Stage of four.
Or what stage?
Hmm?
What stage three?
Three.
Greater than
Um, it has reached maybe the wall or so.
that's stage four, greater than 5 cm.
Okay, greater than 5 cm.
Yes, now. This
Mm.
the AJCC pathology staging for breast cancer. 3 is greater than 5 cm. 4 is direct attention to chest wall or skin. T2 is greater than 2, less than or equal to 5. Remember. Mhm. PTIS, DCIS, PT1 less than or equal to 2 cm in general. PT1 micro invasion less than or equal to 1 millimeter. PT1A greater than 1 millimeter but less than or equal to 5 millimeter. PT1B greater than 5 but less than or equal to 10. PT1C greater than 10 but equal to less than or equal to 20. Okay.
Okay.
Then remember we talked about it, that the whole of PT1 is less than 2. Okay. Anything less than 1 millimeter is micro invasion. But from 1 to 2, then from greater than 2 to 5 is PT2, greater than 5, PT3. C4 is chest wall extension. A is to chest wall. Then B is ulceration. Feel the range. A and B or chest wall and ulceration together is C. Inflammatory carcinoma is D for D. Okay, I just quickly by the way, let's go. Um, Outcomes when not adjusted is worse for males, but when adjusted for stage, if you compare stage 4, stage 4, adjusted for stage, the outcome is what?
It's the same, is
It's equivalent between male and women. In terms of overall, who tends to do worse with breast cancer, males or females?
Male.
Yes, but if you now compare stage by stage disease, like stage 3 of males versus stage 2 of females, stage 4 of males versus stage 4 of females, the outcome is similar. But without that
Hmm.
adjustment, because their own comes up stage 3, stage 4, that's why. Because there's no breast tissue to even expand. You just go to the everything chest wall, so maybe stage 4. Histologic subtypes. What is the most common type of breast cancer histologically in males?
Invasive doctor.
Yeah, so the other ones you can see. Other example subtypes
Was
like
it papillary carcinoma?
and mucinous
And that
carcinoma.
papillary carcinoma is commoner in male than female.
Eh?
Yes.
No, maybe not overall. I think more. maybe proportionally, but in terms of
Okay.
overall, cancers
Yeah.
are really very rare. They're only 1% of all cancers. So, and majority of it is actually doctor. So before you know, so but maybe in terms of proportion, maybe more proportion.
Mm, yeah. Yeah. Of
So lobular carcinoma, how very common in men, true or false?
course.
Why?
They
Male
don't have logos now.
perfect. Male has no lobes. Extremely rare. I mean, they must have manufactured lobes from somewhere. God forbid. Now, male breasts have higher rate of hormone receptor positivity than female breast cancer. True or false?
True.
90%. So what's the treatment?
Hormone
Yes, like tamoxifen.
therapy.
Genetic predisposition and germline mutations. BRCA2. 70-year-old BRCA2 carrier has 6.8% lifetime risk of developing breast cancer. BRCA1, 1.2% risk of breast cancer in 70-year-old male. These are that syndromes associated with it. Paget disease of nipple. Who has more Paget disease? Statistically,
You know with female.
more common in males than in females.
Mm.
And this male Paget disease is often associated with an underlying mass, which is frequently found to be invasive breast cancer. Okay. Okay. Paget disease in male should raise a high suspicion of invasive carcinoma, warranting thorough evaluation. I don't understand. Does it mean that Paget disease of breast is more common in males than females or proportional? I don't understand.
Mm. It's gonna be proportionally.
I don't believe it's overall. Treatment consideration.
Uh,
They don't talk about Paget disease of nipple. Nobody talks about male breasts. So, treatment considerations. Randomized control trials, specifically addressing male breast cancer, are lacking. So they model their treatment after females. Mastectomy, adjuvant radiation, hormonal therapy, chemotherapy by tumor stage and biology. So it's based on the evidence generated from female breast cancers. Okay, we are done. Then what is the percentage of all breast cancers? What percentage of all breast cancers occur in men?
1%.
Which histology type is most common in male breast cancer?
Doctor B.
Massive doctor. Male breast cancer most frequently present at which stage?
3 or 4.
Which of the following best describe the prognosis of male breast cancer when corrected for stage?
Equivalent.
Which of the following is true regarding hormone receptor status in male breast cancer?
Higher than a female.
What is the approximate lifetime risk of breast cancer in 70-year-old male BRCA2 carrier?
6.8%.
Which of the following syndrome is not classically associated with male breast cancer?
Post-Jagas syndrome.
That syndrome, yes. The ones with male breast cancer are Lee, for many, Cowden, Lynch, CYP, polymorphism, HMPC, CP10, PP53, androgen receptor mutations. Paget disease of the breast is,
More common in men than women. That's the proportion.
I don't believe that statement. Which histologic feature is exceedingly rare in male breast cancer?
Lobular.
Which of the following is well-established risk factor for male breast cancer?
Targeting mutation.
Yes, 6.8%. What is the main reason for the worst overall prognosis in male breast cancer compared to female breast cancer?
Delay prognosis with advanced stage and presentation.
Late presentation. Which treatment is central to managing hormone receptor positive male breast cancer?
Tamoxifen.
Tamoxifen. Which of the following genetic mutations is associated with Fanconi syndrome and male breast cancer?
TP53.
This is the truth. What percentage of male breast cancer cases are estrogen receptor positive?
90%.
90%. Okay, good. 15. Which of the following which of the following best describes treatment guidance for male breast cancer?
The extrapolated from female breast cancer protocols.
Okay. Next question, please.
Oh, can I see the African woman with the issue of cosmetic breast implant presented with a painful mass in right breast 5 months after delivery of a healthy full-time infant whom she breastfed. To prevent the foreign likely significant with the diagnosis.
In America, now they will say, why must it be African woman you are using to make the example of breast implant? They say it is racism in medicine. Anyway,
What can we say? A lot of vacuoles.
yes, what did you say? This is ruptured.
Mm.
This is ruptured. We see it in my program from once in a while. It's ruptured implants. Once you rupture, because of this,
Is it the vacuoles?
yeah,
Is that macrophages?
those vacuoles, yes, macrophages will come. Those vacuoles trigger macrophages and everything. They rupture, releasing vacuoles. I mean, those vacuoles rupture and enter the, understand? So they rupture and then they cause macrophages, cause inflammation. So let's just, for the sake of it's a chat, try to look for the answer.
How much do you pay for your subscription per month?
The normal subscription is $20 per month. That should be like fewer pounds. But I have a team subscription because I'm working with other people. Some of our missionaries are using it. So three of us, we are paying for team subscription, which is more expensive actually. So we have like three people, three user domains. We are paying $90 a month.
So you see, is why don't you now, if it's $20, why don't you just make it 20 20 20? Like each person is
No, for the team one, they even say it was 25 for one person. It's more expensive than the this one. But when I went in, it's actually 30. I'm so surprised. I was surprised. I don't know. So if you have it alone, you enjoy it. Although there's some little limitations in that one compared to the teams. Like the the number of prompts you can give in 3 hours for the $20 one is limited to like you have to it's almost limited. I mean, let me say limited. There are maybe 30 prompts in 3 hours. Of course, it's not easy to even get to that. But for the team's own, it's very difficult to get to the limit. So that's why you can, like now when we're studying video, you can type in as many things as possible. I'm not worried about limits. But that one is perfect for an individual because you may not even type up to that in 3 hours. And after that, they'll even give you in the next 3 hours, it will resolve and you'll be able to start typing again. Anyway, so let's look at this. So what's the answer?
Ruptured implant. See,
That's the answer.
ruptured implant.
Uh,
Ruptured implant. Can you not hear me?
I can hear you. But I said that's
See.
not the answer they gave here. Excuse me.
Okay.
Wait, let me see. Wait, let me see. So according to them, the 66-year-old African American woman has cosmetic breast implants, and recently postpartum 5 months after delivery, she's breastfeeding. Painful right breast mass 5 months after delivery. The histologic image provided on H&E stain. The slide shows fat necrosis. Why is this fat necrosis?
They should never know facts in here now.
That's what? Why is this fat necrosis? It not really have look like that. I think some of them like that's why they
I
are
don't
fat.
think so. You are saying lipid-laden macrophages. Is this lipid?
Have you seen fat necrosis before?
I've seen. You see some area of fibrosis.
You see what?
You will see what's it called now? Necrotic adipocytes that are coalescing. You will see fibrosis and then uh, infiltrates in the fibrosis, which contain giant cells.
Yeah, let me see there. I don't know. Right here. So they say here they say this fat necrosis. Let's consider it and be sure. There's no overt bacterial colonization or abscess formation. This is pump classic for granulomatous mastitis. That's idiopathic granulomatous mastitis. Correlation. Idiopathic granulomatous mastitis is a benign chronic inflammatory breast disease that's
What's the answer here? What's the answer in that place? Let's look at the option now.
they called it I want to read through what they think first before we look at that. I don't agree with the answer anyway. But let's look at what they are thinking.
Let's look at the answer in the text itself.
Okay, let me choose ruptured implants. And we are correct. They are the ones that are wrong. So let's look at this one. No. This is what we call silicone mastitis. Because it's not actually breast, it's not actually fat necrosis, I don't think so. Because it's actually silicone. I've seen this kind of things before. Breast implants is not too common in Nigeria. True, of course.
No, true.
Yes. Clear spaces are surrounded by giant cells. Clear spaces, a bunch of that just some giant cells there. They may not be multinucleated, but there are some of these clear spaces are common in surrounded by giant cells, by lymphocytes and histiocytes containing multiple vacuoles of varying sizes. Okay, so let's quickly look at this breast implant pathology. Oh God, sorry. Breast implant pathology. Ah, Maybe it's not allowing me to study. So this breast implant having a low incidence of life-threatening breast implants, they have a low incidence of life-threatening complications. The implant on the right is associated with a fusion. Can you see?
Mm-hmm.
The one on the right is associated with a fusion. This is an implant in the breast of the woman. Is it the right breast? Yes, that's the right breast.
Mm-hmm.
And associated with a fusion. You can see this edematous glacial growth here. This is a fusion in the breast. Cytological evaluation reveals anaplastic T cell lymphoma. Wow. So this patient eventually developed T cell lymphoma because of beauty. The lymphoma was restricted to the capsule and thus had good prognosis. At the time, they didn't go beyond the capsule of the breast implant. God being so merciful. This is an implant. This is how it looks like. Breast implant gross appearance. The most common complication associated with an implant is this. Look at this. You can see the most common complication with an implant. This cellophane paper, is the formation of a thick fibrous capsule. Thick fibrous capsule. The capsule helps prevent dissemination of silicone outside of the breast. However, contraction can result in poor cosmetic outcome. Okay, this is a thick fibrous capsule. This is a good implant. This is a fibrous capsule. This is an implant. This is a fibrous capsule in a form preventing extravasation of the silicone. Albeit this is a capsule. So this is a capsule. The capsule goes from outside to inside. Capsule looks fleshy. So this is breast implant and a mass, magnetic resonance imaging. 1 to 5% of women in the USA have breast implants. Wow, that's a very high number. This mass here, adjacent to the implant, could be carcinoma, fibromatosis, or sarcoma. Implant-associated lymphoma is less likely because seroma is not present. It's seroma. Seroma is like fluid, right? Are you with me? Hello? Hello? Hello, sir. Hello? Hello, sir, are you with me? Breast implant pseudosynovium. The implant capsule is lined by pseudosynovium, consisting of a layer of macrophages that appear oriented perpendicularly to the implant. The surrounding tissue is densely fibrotic and paucicellular. Breast implants. This is silicone. Both the extracellular and intracellular silicone will be present in the capsule. The variety of cell sizes and the presence of occasional pleomorphic nuclei may mimic liposarcoma. It is important to note the presence of giant cells, foreign material, and the clinical setting. Breast implant capsule. Foreign material may be present in capsules due to silicone bleach. And material is used to form a textured surface. These empty surface spaces are filled with refractory material that is likely silicone. There is a surrounding lymphocytic infiltrate. Refractal appearance. Fractal material often associated with histiocytes and giant cells. The refractal quality can be enhanced by increasing the contrast, by lowering the condenser or closing the aperture diaphragm. silicon in histiocytes. Intercellular silicon can fill histiocytes as numerous square spheres or vary sizes. The silicon can indent the nucleus, creating a notch shape. This pattern can mimic the appearance of lipoblast and liposarcoma. Core needle biopsy. Foreign material. Free injection of foreign material for augmentation results in multiple masses difficult to distinguish from cancer. Multiple core needle biopsies may be necessary to evaluate the masses for possible malignancy. Breast implants subpectoral are placed below the pectoralis muscle. In this case, the fibrotic implant capsule. Don't need all these things. This. Polyurethane textured implant. Fractile things. Foreign material. T cells, CD3 cells can be there. Calcifications can occur and can complicate the detection of cancer-associated calcifications during mammographic screening. Infection can occur in the perioperative period with polymofollicular leukocytes. The direct injection of substance into the breast for augmentation creates multiple radiopaque masses. This procedure results in poor cosmetic outcome and makes radiologic evaluation of carcinoma almost impossible. Identify foreign material. Numerous substances such as organic oil, silicone, and paraffin have been injected into breast for augmentation. The type of substance injected cannot be determined with certainty based on the histologic appearance or inflammatory reaction. The cellular dermal matrix. Squamous metaplasia may occur. Fibromatosis may occur. It can be into regional lymph nodes after rupture.
Mhm.
It can be associated with anaplastic-like T-cell lymphoma. Where did you go? Are you with me? I didn't get. Where did you go? I see
I'm
here.
with you. I'm with you.
I was calling you before. You're not responding.
Mhm.
You're sleeping.
Yeah.
Uh,
No, no problem. Okay, you can continue. Doctor implant.
Implant can be predisposed to large cell anaplastic-like T-cell lymphoma. Is anaplastic-like T-cell lymphoma in an implant. Pleomorphic nuclei, horseshoe shaped. Breast implants related anaplastic-large cell lymphoma. And it stays post-focally positive for EMA, for the large cells. They are CD30 and CD43. Positive. Anyway, so let's quickly look at the points quickly, and then we'll close. In external lymphadenopathy, it was why they mentioned African American, because they want you to confuse it with sarcoidosis. Sarcoidosis is present in African American. Breast involvement is rare and usually part of systemic disease. And sarcoidosis. And sarcoidosis will have well-forming non-caseating granulomas, no significant necrosis. So let's look at staph. No. Ruptured implant. This patient has a history of cosmetic breast implants. Even without overt rupture, gel bleed, small silicone leakage can cause foreign body granulomatous reaction. Silicone is dissolved during processing, H&E, leaving behind clear spaces and empty vacuoles. Do you understand? Surrounded by macrophages, multinucleated giant cells, and lymphocytes. Intracellular silicone appears as multiple vacuoles of different sizes inside histiocytes.
Mhm.
You see clear vacuoles within histiocytes and multinucleated giant cells consistent with silicone granuloma. The diagnosis matches the history and histology best. Let's look at
That's
this.
good.
So if you look at this, these are clear species of silicon that were silicon is dissolved in HIE processing, leaving clear species. Now, since that's cytoplasmically, you can see sometimes see this cell, the cytoplasm filled with silicon. You know, sometimes you have multinucleated giant cells and these two sites. Okay, good. So let's expand these points and be gone. If you don't it. You can't solve it now.
Before life is over for me, it's as useless as not having life.
Why?
Because the idiom not having now put another kind of life for me. Life that have zigzag. I don't know if it was doing it.
If you don't for one reason.
Tell me that I want to buy my children from this life. No. Why people are like this?
Overview. Teaching points. Benign inflammatory breast disorders. Diagnostic insight. The spectrum of benign breast masses. Benign inflammatory conditions of the breast can mimic malignancy clinically and radiologically, often presenting as painful mass. Accurate diagnosis require integrity clinical and histopathology key findings. Key scenarios: breast implants raises suspicion for silicone mastitis. Postpartum lactating women, lactational abscess or granulomatous lobular mastitis. Giant cell inflammation, also. Giant cell inflammation should prompt consideration for sarcoidosis. Silicone mastitis occurs when silicone leaks from breast implants, either due to frank rupture of the implant and gel bleed. Subtle leakage to intact shell. Histology. Silicone is dissolved during processing on H&E. Clear vacuole spaces are found in the tissue. These spaces are surrounded by multinucleated giant cells, histiocytes like macrophages and lymphocytes. The cellular silicone. Multiple vacuoles of varying sizes within histiocytes. Clinical clue: history of breast implants and painful breast mass should raise suspicion for this diagnosis. Lactational abscess is common in breastfeeding women. Bacteria can enter through nipple cracks. Staphylococcus aureus is the most frequent organism Inflammatory filtrates include neutrophils, ensure abscess formation. Clinical clue, painful swollen breast mass accompanied by erythema and warmth. Granulomatous lobular mastitis is in women of reproductive age after postpartum or breastfeeding. Non-infectious. Corynebacterium can be implicated. Lobulocentric granulomas, microabscesses, multinucleated giant cells, negative for stains, may form draining sinus tracts. Identification in young women with recent pregnancy, granulomatous lobular mastitis, sarcoidosis, common in African and American women. Breast involvement is rare and usually part of the systemic disease. Well-formed, non-persisting granulomas, no significant necrosis. Cystocytes do not show multiple intracytoplasmic vacuoles. There will be other signs of granulomatous, sarcoidosis. Interpreting the image, clear spaces, vacuoles created by the dissolution of silicon during tissue processing. Multinucleated giant cells, lymphocytes, lymphocytes with multiple intracytoplasmic vacuoles of varying sizes. This pattern is the hallmark of silicon mastitis. Silicon granuloma, confirming the foreign body type granulomatous reaction to silicon. So silicon mastitis should be high on the differential when there's history of breast implants and biopsy shows vacuolated histiocytes and giant cells. Lactational abscess presents with neutrophilic abscesses and is often culture positive. Granulomatous lobular mastitis is lobulocentric, often with microabscesses and aggregating for culture. Sarcoidosis is rare as an isolated breast process and typically forms well-formed granulomas without vacuolated histiocytes. This is very important in diagnosis silicon mastitis. That brings us to the end. Hello, sir, are you there?
I'm there.
Okay, I thought you slept off again.
I'm there.
Okay. Do we continue?
Yeah, let's do a little more.
Okay. Yes, the few questions here. The questions are
There's still like 19 more.
just answer the questions in 5 minutes. Less than 5. Just be answering yes, no, quickly. If you answer, the faster we are, the better for us. A woman with breast implant present with painful breast mass. Which of the following is the most likely diagnosis if histologists show clear vacuole surrounded by multinucleated giant cells?
Silicon mastitis.
What is the most common organism implicated in lactational abscess?
Staphylococcus aureus.
Which histologic feature best distinguish granulomatous lobular mastitis from other causes of granulomatous inflammation?
Lobulocentric granuloma.
Containing microabscesses. Which condition is most likely if a draining sinus tract is present but cultures and special stains are negative? Granulomatous
Okay.
mastitis and form tracts that drain into the skin. Which of the following is not typically associated with silicon mastitis?
Positive bacterial culture.
Yes. A breast biopsy shows well-formed non-cystic granuloma without vacuolated histiocyte. What's the most likely diagnosis?
Sorry. Sarcoidosis.
Yes. In which condition are intracytoplasmic vacuoles of varying sizes within the histiocyte a key finding?
Silicon mastitis.
A 30-year-old breastfeeding woman has a painful erythematous breast mass. Biopsy shows neutrophil-rich inflammation. Which diagnosis is most likely?
Lactational abscess.
Which condition is associated with mediastinal lymphadenopathy and breast granulomas? Silicon sarcoidosis. In granulomatous lobular mastitis, which microorganism has been rarely implicated as a causative organism?
Corynebacterium.
Copensteady. Which histologic feature is typical of ruptured breast implant reaction? Clear vacuoles surrounded by giant cells. Which condition is most likely to be positive, have a positive AFB stain? Tuberculosis mastitis. Good. Which clinical setting increases suspicion from granulomatous lobular mastitis?
Recent pregnancy and breastfeeding.
What is the most common reason for worse prognosis in sarcoidosis with breast involvement?
Systemic involvement.
Which of the following statements best describes clinical mastitis histology?
12 spaces surrounded by giant cells and isocytes.
Diabetic mastopathy.
Let's see.
So let's
All
answer.
of the following diabetic artery except let's pick up it now.
The B.
I would say E.
Or E. I'll say E. I'll say E. Okay, let's see. Okay, because I think there should be, it's not that it should be associated with breast cancer, right? No, I don't agree so. I don't agree it's associated with increase, but I think that it should not always be type 1. Let's see. Yes, I'm correct. E is the answer. Because of that word, always associated. These questions are not real questions. They just will help us study. Diabetic mastopathy is prone to single or multiple recurrences in the same breast or the contralateral breast. Yes, it recurs both locally and contralaterally. Huh? No, 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 no. No, the clotrimazole now. Okay. Diabetic mastopathy is known for recurring locally on the contralateral. Patients often develop new masses over time, which can cause ongoing clinical concern and repeated biopsies. Patients with diabetic mastopathy are not at increased risk of developing breast cancer. True. The benign entity. On physical examination, a hard, non-tender, palpable breast mass, clinically suspicious for carcinoma, is frequently found. It's present as a hard, yes. It is a fibroinflammatory breast disease associated by dense fibrosis with perivascular, periductal, and perilobular lymphocytic infiltrate associated with ductitis and sclerosing lobulitis. True. They have dense keloid-like fibrosis, prominent perivascular, periductal, perilobular lymphocytic infiltrates, often associated with lobulitis or ductitis. Is diabetic retinopathy is most commonly associated with long-standing type 1 diabetes. It's also reported in type 2 diabetes. Non-diabetic individuals with autoimmune disease like Hashimoto thyroiditis, Sjogren's syndrome can also have it. So let's see if you are right. You are right. Okay. Hashimoto thyroiditis, Sjogren. Okay. Diabetic mastopathy. Lymphocytic mastopathy, the mammographic appearance, forms breast masses that may be palpable or form circumscribed or ill-defined mammographic densities. In this case, a clip from a prior core needle biopsy is present within this ill-defined dense mass. Lymphocytic mastopathy core needle biopsy has two distinctive histologic features. The interlobular stroma is densely hyalinized and glassy in appearance. In addition, there are dense lymphocytic infiltrates that are centered around ducts, lobules, and blood vessels. Lymphocytic mastopathy gross appearance. The dense interlobular stroma associated with lymphocytic mastopathy forms very hard white masses as seen grossly. The borders are not well defined. Multiple masses may be present. Lymphocytic mastopathy the infiltrate can be so dense that it obscures the epithelium. Wow. Lobules are sparse and small. The basement membranes are often markedly thickened. Thickened basement membrane around lobules, significant inflammation, masking and shrinking the lobules. Lymphocytic mastopathy, corneal biopsy. The diagnosis of lymphocytic mastopathy can be strongly suspected by viewing a glass slide with naked eyes. Blue clusters of lymphocytes stand out in the background of uniform pink dense stroma. Lymphocytic mastopathy, the predominant component of lymphocytic mastopathy is very dense stroma. The hardness of the lesion can make it difficult to sample with needle biopsies. Epithelial elements are sparse, and lobules are generally small and atrophic. Lymphocytic mastopathy, the lobules are characteristically atrophic in appearance, and the basement membranes are typically markedly thickened. A possible association with abnormal glucose deposition has been suggested for the abnormal stromal changes. They have thickened basement membrane, shrunken lobules, multiple inflammation around them. The lymphocytes of lymphocytic mastopathy are predominantly small B cells, as shown in this immunohistochemistry study for CD20. B cells also predominate in other reactive inflammatory lesions of the breast. Lymphocytic mastopathy with epithelial stroma cells. The stroma cells of lymphocytic mastopathy can occasionally have a large nuclei and have a rounded shape. These features can raise concern for diffusely infiltrating carcinoma. Lymphocytic mastopathy epithelial stroma cells. The stroma cells of lymphocytic mastopathy can have enlarged nuclei, and the cells may appear epithelioid. However, these are fibroblasts and are immunoreactive for CD34 and negative for cytokeratins. Fibrous nodule, core biopsy. You show dense collagenized interlobular stroma. Epithelial elements may be absent or scant and atrophic in appearance. A lymphocytic infiltrate is not present. Chronic lymphocytic leukemia, small lymphocytic leukemia, lymphoma, corneal biopsy. CLL, SLL can closely mimic lymphocytic mastitis as the small lymphocytes can surround lobules and blood vessels. However, instead of being limited to these areas, the tumor extends into the adjacent stroma. The stroma is normal in appearance and not densely hyalinized. IgG4 related sclerosing mastopathy. IgG4 related mastopathy consists of infiltrates of lymphocytes and plasma cells in a sclerotic stroma. Unlike lymphocytic mastopathy, the inflammatory cells are the prominent components of the mass rather than the stroma. IgG4 related sclerosing mastopathy has the prominent component of plasma cells, and the number IgG4 related plasma cells is increased. In contrast, the cells in lymphocytic mastopathy are predominantly small B lymphocytes. T-cell lymphocytic globulitis is identified primarily in women with germline mutations in BRCA1. A dense infiltrate of T cells surrounds the lobules. A minor lymphocytic infiltrate surrounds adjacent lobules. The lobules do not appear atrophied, as seen in lymphocytic mastitis. Lymphocytic globulitis in BRCA1 as a carriers consists predominantly of CD4 positive T cells, and the main lesion in the adjacent lobules. The lymphocytes associated with some type of carcinomas are also predominantly T cells. So diabetic mastopathy is also called lymphocytic mastopathy. And let's go back to the expander and this thing and we're done. We are teaching points, and then we don't have time to really go through the main text, unfortunately. Diabetic mastopathy is a benign fibroinflammatory breast disease that was initially recognized in patients with type 1 diabetes mellitus. However, further studies have demonstrated that it can also occur in patients with type 2 diabetes mellitus, non-diabetic individuals with autoimmune disorders like Hashimoto thyroiditis and Sjogren's syndrome. Wow, this thing is so good, man. So good. Sex distribution, most cases are reported in women, especially premenopausal women. Rare cases have been documented in men. Okay, occasionally in association with gynecomastia. Histopathologic features. The hallmark histopathologic feature findings of diabetic mastopathy include dense keloid-like fibrosis. The fibrosis can be extensive and hardenized, showing keloidal characteristics. Predominantly, lymphocytic infiltrates are seen, which may include variable number of plasma cells. These infiltrates typically surround lobules, ducts, blood vessels, perivascular distribution, epithelial fibroblasts. These are unique spindle to plumb fibroblasts with abundant eosinophilic cytoplasm. When present, epithelial fibroblasts are highly diagnostic of diabetic mastopathy, although they are not seen in every case. Key diagnostic clue is a combination of dense fibrosis, periductal, perivascular lymphocytic infiltrate that forms classic picture of diabetic mastopathy. Diagnostic strategies, the role of core needle biopsy. Clinically and radiologically, diabetic mastopathy mimics breast carcinoma, presenting as a hard, non-tender mass. The rule of malignancy, core needle biopsy is essential. Monitoring recurrences. In patients with proven diabetic mastopathy, core biopsies can also be used to monitor recurrent lesions to avoid overtreatment. The typical needle biopsy may reveal clusters of benign ductal epithelial cells, lymphocytic infiltrates, epithelial fibroblasts. The presence of epithelial fibroblasts in the fibrotic stroma is considered pathognomonic when found. epithelial fibroblast. Yes, yes, something like that.
You shouldn't be over here. That's when you got on.
No, I did not. Pathology, what we know. Although the exact pathogenesis of diabetic mastocytopathy is still under investigation, the leading theory involves non-enzymatic glycation of proteins. In diabetes, hyperglycemia leads to the formation of advanced glycation end products. These glycosylated proteins are cross-linked and resistant to degradation. They become deposited in the cellular matrix of tissues, including the breast. Neurogenic stimulation. The deposition of these proteins may provoke a chronic immune inflammatory response, leading to fibrosis, chronic inflammatory infiltrates. Diabetic mastocytopathy can be challenging ideologically because it mimics breast carcinoma. However, some distinctive patterns are noted. Dense breast parenchyma, dense dense breast parenchyma, dense glandular tissue, asymmetric densities, parenchyma deformity. Discrete mass lesions are not typically visualized, making diagnosis challenging. These non-specific findings often lead to further evaluation with ultrasound or biopsy. Diabetic mastocytopathy is a benign breast condition associated with type 1 diabetes, type 2 diabetes, and non-autoimmune disorders like Sjogren's syndrome and Hashimoto thyroiditis. Histology shows dense keloidal fibrosis, skin infiltrates, and occasionally diagnostic epithelial fibroblasts. Early biopsy is crucial to differentiate diabetic mastocytopathy from malignancy and can be used for monitoring recurrences. The most accepted pathophysiology theory involves accumulation of advanced glycation end products which provoke chronic immune response. Mammography often shows there is a symmetric breast tissue without a discrete mass, further complicating clinical evaluation. Treatment is unnecessary once carcinoma is excluded. Benign illness is performed. No treatment is normally done. Okay. Hello, sir, are you still there?
Yeah. You see there. Hmm?
Yes. So question number 1, which of the following best describe diabetic mastocytopathy?
Benign fibromyalgia condition is the best.
Which etiologic feature is pathognomonic when present in diabetic mastocytopathy?
Epithelial fibroblasts with dense fibrosis.
Diabetic mastocytopathy is most commonly associated with which type of diabetes? Are you there? Number 3. Both type 1 and
No,
type 2.
no. Okay. True regarding this cover first. Okay. There's my increase with
The following statement is true regarding the risk of breast cancer and diabetic mastocytopathy.
It does not increase.
Which of the following findings is most likely on mammography of diabetic mastocytopathy?
Okay.
Dense breast parenchyma.
Okay.
Symmetric density, dense granular tissue. Which cell type predominates in the inflammatory infiltrate of diabetic mastocytopathy? The lymphocytes, sometimes plasma cells in IgG formulated disease kind of thing. Which of the following is the best next step when a hard, non-tender breast mass is found in a known diabetic mastocytopathy patient with a new lesion? A repeat core biopsy. What is the primary proposed pathophysiologic mechanism in diabetic mastocytopathy? Non-enzymatic glycation of matrix proteins provoking immune response. In which patient group is diabetic mastocytopathy most frequently reported? Premenopausal women with long-standing type 1 diabetes. Which of the following is true regarding epithelial fibroblasts in diabetic mastocytopathy? They are pathognomonic, but not found in all cases. Diabetic mastocytopathy has been reported in which of the following non-diabetic conditions? Hashimoto thyroiditis and other autoimmune disease conditions associated with diabetic mastocytopathy. What is the typical finding in diabetic mastocytopathy? Hard, non-tender, palpable mass that's often mistaken for carcinoma. On corneal biopsy, what combination of findings is suggestive of diabetic mastocytopathy? Dense fibrosis, perivascular lymphocytic infiltrates, and epithelioid fibroblasts. So the following statement is false regarding diabetic mastocytopathy. Type 1 diabetes is not the exclusive one. Which of the following best describe gender distribution of diabetic mastocytopathy? Most common in women, but rare cases are reported in men, often affiliated with gynecomastia. Hello, sir.
Yeah.
Let me release you now so that you can continue.
Then I think we can even do in the afternoon. I don't know. Yes, we can do in the afternoon. That will be your own morning.
Tomorrow morning, I'm going for an appointment.
Okay, okay.
Are you working on Saturday?
I'm not working on Saturday. Maybe towards evening then tomorrow. Today.
Can you find a time when you'll be free? Let's have like 6 hours. I want us to finish this breast this week. We are in question number 31.
Next time will still be next week.
Let's see how yeah. For the way we started, you were more active, but recently, sometimes you sleep. Although, let's say you actually participated very well until they called you in or something like that. So,
You didn't do it yesterday. It was Tuesday.
oh, he's still sorry. So
Yeah, if you have time, I'm not going to work tomorrow. If you have time, you let me know.
tomorrow I have an appointment. Oh, I didn't know. I have to go with my family to an appointment. Oh,
Exactly.
no problem. But we need to finish this breast. I want us to start head and neck. I want to start head and neck, endocrine, and let me see.
Cytopathology.
Those are two parts. What if you do head and neck next?
Huh?
What if you do head and neck next? Do you like that?
It's okay.
Head and neck and
I don't.
endocrine are together. You know that head and neck and endocrine is a very big topic. Thyroid, all the thyroid, they are very common. All these oral lesions, head and neck lesion. Head and neck is a very huge area. We combine head and neck and endocrine. I will combine it with soft tissue
It's okay.
so that we can pursue that area. Understand? So very, very strategic. I mean, don't be blind. Understand? So it's okay. Sorry, I wish we can continue. I'll go back and continue on the bone cases and we'll see how it goes.
All right. Thank you.
Thank you, sir. God bless you, sir.
You too. Bye.
Goodbye, sir. Let me jump for the weekend.